Hello, and welcome to the League of Women Voters of Lane County's virtual webinar. I'm Charleston Kaler, president of the Lane County's League, and thanks for signing in. You'll have an opportunity to ask the speaker questions at the end of his presentation. Go to the chat button and type in your questions then. First, a bit of business. Stating the obvious, it's a bit busy around the league at this time, but you can see the fruits of our labor at our website, lwvlc.org. There are links and dates for candidate debates, gobs of voting information, links to view our ballot measure discussions, and Third Thursday presentations, including this one. The people of Lane County live on the traditional land of the Kalapuya people, whose descendants are citizens of the Confederated Tribes of the Grand Ronde Community of Oregon and the Confederated Tribes of the Siletz Indians of Oregon. We honor with gratitude the land of the people who have stewarded the land. We reaffirm our commitment to stewardship through our work. Dr. Patrick Luedtke, Lane County Senior Public Health Officer, is today's speaker and will speak on people, pandemics, and possibility. Dr. Luedtke is, I'm sorry, I'm using the Ohio pronunciation of your name. Dr. Patrick Luedtke is a preventative medicine and primary care physician. He serves as Lane County's Senior Public Health Officer, as well as the Chief Medical Officer for the Department of Health and Human Services, 9 divisions and 6 clinics. Dr. Luedtke received his MD from the Medical College of Wisconsin-Marquette University. He completed his preventive medicine training and a Master's of Public Health degree at the University of Utah, and his internal medicine training at the Naval Hospital, Oakland, California. Prior to joining Lane County, he spent 11 years in Utah at the State Health Department, where he served as the state's Public Health Laboratory Director, Deputy State Epidemiologist, Acting State Epidemiologist, and Adult Medicine Director, Medicaid clinics. He has also been a public health professor at the University of Utah, serving as the course director for the MPH and PhD in Environmental Health and Toxicology coursework. Prior to Utah, he served 12 years as an active medical officer in the U.S. Navy. He regularly appears on local television and radio news to talk about public health. You can also listen to his weekly radio show, Health Matters, on KWVA 88.1 FM in Eugene. I'm honored to introduce Dr. Patrick Luedtke.
Thank you so much, Charlize. I sure appreciate it. Thank you for the opportunity to meet with your members today, and I thank you for the invitation from the League. You know, it's interesting, when you get an invitation of this sort, you try to sort through what would be of most benefit to members. In addition, you also try to look at topics that are topical. And certainly one thing that's topical now is the pandemic, COVID-19. But in the public health space, there are so many other daily challenges that we deal with, ranging from obesity to substance use, such as opiates and cannabis, even psilocybin. There's a measure this year in the voting next month. We have an opportunity to weigh in on that. We have challenges in other spaces, including sexually transmitted diseases. So I think that looking at all of those and then trying to get a sense of what would fit best into our limited time together, I'm going to focus on just a couple. And the first will be where we came from with the pandemic, where we are today, and where we think we're going. And before I continue with that, I want to let everyone know that there'll be plenty of time for questions. I'm going to have a small presentation, not too long. And in the spirit of Winston Churchill, who famously said when asked how he approaches community presentations, he said, "Be bright, be brief, and be gone." I will do that, but I will be gone with the presentation and instead move to Q&A. So let's talk about this pandemic. COVID-19 is a coronavirus. I'm sure you all know that. There are many coronaviruses out there. There are 4 main categories of coronaviruses that our molecular biologists and microbiologists use to classify them. And this particular pandemic virus is in the beta subgroup. And there are several beta coronaviruses that circulate every year and cause the common cold. Every one of us have had a common cold from one of the beta coronaviruses. And we use some of the information that we've had over the decades of the other beta coronaviruses to help us perhaps do some modeling and some visioning for this coronavirus. One of those is that the beta coronaviruses that cause the common cold typically peak in November, December. And that's why you probably heard many of us in the public health space wondering how bad it was going to be in the fall with this COVID-19 virus. In addition, of course, there are respiratory viruses. And when the cold and rainy weather comes, what do? We go inside and we share a lot more air than we do when we're outside. So we all had some concern about what would happen in the fall. That being said, if you look at the beginning of this for the state of Oregon, the first cases were early March, right around March 1st, actually. It's unclear who gets the distinction of being number one. It may very well be it was Eugene. Our first case did become symptomatic on March 1st. We got the first bit of data in the late morning of that day. I've asked the state to tease through it. Not that I want to be the county that had the first coronavirus case, but it's possible that it actually was a person in Eugene. So the first several cases were all symptomatic on March 1st in the state of Oregon. And we were at a space, as many of you know, of only having knowledge from who came before us. So there was Wuhan, China, and their really terrible outbreak. And then, of course, Seattle was erupting and New York City was about to erupt. And we learned some information from them, but we were all learning this together. And that is hard. When I started to title this talk about people, pandemics, and possibility, the people part is we as people don't do so well with uncertainty. I was tasked with leading the provider community early on to try to make sure that we are able to test people quickly and work with Peace Health and Mackenzie Willamette, the Oregon Medical Group, all these other clinical practices in our community, and to try to figure out the systems we're going to put in place to make sure that our community is safe and we find cases early, do isolation and quarantine, and prevent further cases. And early on, we didn't even know where the virus was going to be found. The first recommendation was swab people's nose, swab people's throat, and draw blood, and send all those samples to our state public health laboratory up in the Portland metro area for testing. Within a couple weeks, we realized we can't recover this virus in people's blood. That's an interesting piece of information. So we dropped the blood part of it. And that uncertainty is a challenge. It's a challenge for all of us. We also were unclear of this, the spreading of this virus in terms of, are you more likely to spread it once you become symptomatic, like SARS, which is also a beta coronavirus, if you remember back in 2003, or is it possible to spread before you become symptomatic, which really makes public health professionals nervous because we don't know who has the virus and how they may spread it before they become symptomatic. So turns out that you can indeed spread this before you become symptomatic. Up to about 2 days before you're symptomatic, you can actively spread this virus. That makes it really hard for public health to prevent the spread. If someone is not symptomatic, they go about their life, work and play as they normally would. And then a couple days later, they become symptomatic, and then we have to backtrack and say, oh, where were you 48 hours ago? Who did you contact? And then public health contacts those people. So a good deal of uncertainty early on, February, March. We were lucky that our state laboratory was able to bring up PCR testing, that's fancy molecular testing, but the volume wasn't enough. And that testing really needed to increase across the state. The other area that we in Lane County are lucky is we've had several clinical vendors step up and do testing locally. Now, Oregon has 36 counties, and several of those counties do have local COVID testing, but quite a few do not. So they're reliant upon these long chains with a long turnaround time to get test results back. So we're lucky. We have Peace Health doing local molecular testing, Mackenzie Willamette Hospital, the University of Oregon doing local PCR testing, again, that fancy molecular test. And we have a couple other practice groups that are doing some of the antigen testing. And we typically have a turnaround time for test results from those testers of less than 24 hours. That's just wonderful. We should consider ourselves very fortunate in that regard. The larger vendors that had supplied much of the testing before these other entities I mentioned stepped up, we slowly watched their turnaround time for testing increase. 2 days, 4 days, 6 days, 8 days. We got as long as 2 weeks turnaround time, which is not only frustrating for patients to know, do they really have coronavirus, but public health can't do much. If someone was tested on, let's say, October 1st, and we don't get a test result until October 15th, there are 14 days of activities to track, and that's really tough. That's tough public health. So again, we move forward into April, into May, with more and more testing coming online. better understandings of the virus, better understandings of how it is that we can test and interpret those results. And then we moved to open up our communities. And if you remember, we went to phase 1 first. Each phase lasted about 2 weeks. If you passed the phase, you moved into phase 2, where the indoor and outdoor gatherings could be bigger and bigger. So by the time we hit mid-June, we were into phase 2, and everybody was looking at phase 3. When are we going to hit phase 3? And phase 3 is going to be a challenge. We're not going to get there until we have a lot of people with immunity. So we've been in phase 2 since then, and we have had our share of cases, ups and downs. So that's a bit of the past history. Let's talk about right now. We moved from 110 cases in mid-June to a month later, 440 cases. And we chose a strange date. I'll tell you why. We started to look at the 24th of each month for really some local technical reasons. And part of it had to do with the number of staff we had in-house, so we could crunch numbers. But on June 24th, Lane County had 110 confirmed COVID cases. And a month later, we had 440. So that's a 4-fold increase. That's pretty big. And we were looking deeply into that space, wondering, well, we had community marches at that time. We had a lot of people who were, I think, full of COVID fatigue and wanted to go outside and enjoy the sunny weather and exposing themselves perhaps to other larger groups. And that may have explained the 4-fold increase. When we look a month later, on August 24th, we had only a 50% increase. We went up to 660 people from 440. And that increase was about what we were estimating, actually, looking at activities, looking at the infectiousness of the virus, looking at our abilities to do contact tracing and isolation and quarantine. And then if you fast forward to September 24th, we increased from 660 to just shy of 1,200. Roughly a doubling of cases and a huge increase in overall numbers. And today, as of 9:30 this morning, we have 1,959 cases with 23 deaths, 17 people in the hospital right now with COVID, and 175 people in our community currently infectious with COVID that we're aware of. Of course, we don't have our finger on every pulse, so to speak, but we're aware of that many. So that's the current status today. If we continue on the track that we've been on in the last 4 weeks, a month from then, on October 24th, continuing with the 24th of each month, we'll probably have 2,200 to 2,300 cases in our county. And we're on the steep part of the curve, and we really don't want to be there. It's a challenge for us to continue to track that number of cases. At any given time, we have 600 or 700 persons under monitoring that we are talking with every day. We have several dozen public health people doing this work to make sure that they are doing okay. If they were in quarantine, they didn't become sick. If they did become sick, we need to get them back in to be tested, etc. And this is a part of the curve we don't want to be on, especially as that cold weather comes. And as I mentioned at the outset, coronaviruses, especially beta coronaviruses, really like to peak in November, December. So we are concerned about that. So I want to talk briefly about death rates. We've only had, as of today, again at 9 a.m., 23 deaths. And we're a county of 385,000 people. Certainly every death is something we want to avoid, but the number of 23 is pretty darn low. And we have had our share of queries regarding that. So for example, are we really able to count all the deaths? Are there a number of deaths that have occurred that we probably did not actually get tested for COVID? We think those numbers are small. We work with the county medical examiner, who has a fair number of deaths under his jurisdiction, although certainly not all deaths. Traffic accident deaths, homicides, suspicious deaths, they all go under the county medical examiner. His name is Dr. Davis. Dr. Davis has looked at all of his data. He has not seen a big increase in deaths over last year, especially pneumonia-related deaths or respiratory deaths. So we don't think that we're missing a huge number of deaths. And I suspect we'll have a question on that when we get to the Q&A session. But we are looking at that. We're looking at that regularly, trying to understand, is our data system correct? Are we really looking at the data in an appropriate way and making sure we're not missing anything? So I went through numbers. We know in public health that numbers numb and jargon jars. I try to stay away from those things. But sometimes in public health, you need to talk about numbers. So let me talk about groups instead of numbers. So of those large increases in cases, where are they coming from? In the last 3 to 4 weeks, when we've had this big increase in cases in our county, where are most of the cases and the outbreaks coming from? And the largest group by far is private homes. So people tend to let their guard down when they get home. Boy, I let my guard down. I let my hair down. I'd let it down more if I had even more of it. But you know, you relax when you're at home. And I think that we need to make sure that people understand there still is a risk at home. And some homes are nuclear homes where it's mother, father, sister, brother, and grandparents are there, and grandparents are older and may have conditions that put them at higher risk. We really have to help in that space. But the big increase in cases, number one, is private home transmission. Number two is the workplace, and surprisingly, it's been all over the shore. I guess we've had cases in banks, cases in daycares, we've had cases in restaurants. We've had multiple cases and multiple outbreaks throughout all types of businesses. So that's number two. And then number three are these social gatherings. And this may be where we're pulling in more of the college student age. I suspect I'll get a few questions on college students. Are they driving this large increase in cases? And the social gatherings have included things such as retirement parties, birthday parties, family reunions, and we've had fairly large caseloads from those types of events, those social gatherings. And one of the messaging we really want to push out is we do want to honor those milestones in life. You know, I remember when I was 21 and you know, you could go out and have a beer. That's a pretty cool thing. Or you're celebrating your sweet 16th birthday for your last child and you want to have a party with their friends. And we really want to make sure that people know the virus is still out there. We're not in a space we want to be. And do you really have to have a sweet 16 party with 50 people? Could you just have it with, you know, 5 or 6 or 7 and really plan about social distancing and try to keep not only your family and loved ones safe and healthy, but thinking about your community as well. So we're working on community messaging in that regard. And we are trying desperately, although maybe desperate sounds too desperate, we're trying very hard to ensure that that messaging goes out, not only in a responsible way, but in a persistent way, because human behavior comes and goes. We all develop good habits, and then somehow 6 months later, they become a bad habit, and we need to be nudged into a good habit again. And it's the same thing with wearing masks and social distancing and avoiding large gatherings. We all need to continue to hear about these sort of things. So I want to talk a bit now, a couple more things, and then we'll move to Q&A. What does the future look like? You know, possibilities, that was the last P in my title here. And we're going to get a COVID vaccine. In fact, I think we're going to get several. On this planet right now, there are approximately 200 vaccines in trials, and our federal government has contracted with 6 major vendors to produce, you know, millions of doses for use in our country, and our satellites, our protectorates. And certainly amongst 200 vaccines, a few of those vaccines are going to meet the safety criteria and the efficacy criteria to get to market. So it's going to happen. Now, my crystal ball is no clearer than anybody else's. I may be reading other articles and such that some of you on this call today are not reading, but still, my crystal ball is a little bit cloudy. But it seems pretty clear we're going to get a COVID vaccine that's safe and efficacious. It's going to trickle in at first. Probably we'll get the first few doses in late November, a few more in December, and we have a prioritization criteria to make sure that we look at the highest risk people or the highest need people through phases 1, 2, 3, and 4. And that first phase will include vaccinating first responders who are out there to pick us up at our house if we're sick or get us off the street and bring us into the hospital. It will also include healthcare workers at specific risk. We'll move on to phase 2, which will be other critical workers, people who operate critical pieces of our society, and that will include teachers too. Phase 3 will be when we get to vaccinating kids, and then phase 4 will be everyone else. I suspect it won't be kids. Phase 3 will probably happen in the second quarter of next year, April, May, June, but we have prioritization criteria for that. So that's a lot of words. Suffice it to say, COVID is coming, a COVID vaccine is coming. There will be several of them. What I think is important to know is they will not be interchangeable. Most of them are 2-dose vaccines. So you get 1 dose, and either 21 days later or 28 days later, you got to get the second dose to make sure you achieve enough immunity to be protected. And you can't just get 1 dose at your primary care provider and then go to a pharmacy to get the second dose, because those 2 organizations may not have purchased the same company's vaccine. So just keep that in mind. And then I'm going to finish now before the Q&A with the other challenges that happen this time of year. And many of you know that the one reliable epidemic we have each year is influenza. It's something that we can count on. By November, we're already seeing cases in our community. By December, January, we're moving towards a peak. Usually in February or late January is the peak. Although some years, like 2 years ago, our peak didn't happen until way into March. And there are some challenges if you try and look at getting people who want the flu vaccine vaccinated and dealing with a new pandemic vaccine coming in. We're not going to have time to do all the research we'd love to do to see, can we give the flu vaccine and the COVID vaccine on the same day? If somebody has, let's say, immunocompromise, and we give those two vaccines on the same day, will they get a response to both of them? We're not going to have time to do that. So the safest thing to do for persons who want to get protection from influenza is get your flu vaccine now. In particular, get it before late November when the COVID vaccine starts to trickle in. We in our clinics, we only have so many needles, so much bandwidth for nurses. If we have to give flu vaccine at the same time we're going to be giving a mass vaccination for COVID, it's going to be a challenge to get people vaccinated. So the nudge to every one of you today is to get you and your loved ones vaccinated for flu now, and do it before November 30th so that we are all ready, not just each of us on this call today, but everyone in the clinics are ready to shift from doing flu vaccine to moving to COVID vaccine and trying to get as much protection as we can when those COVID vaccines start to trickle in. So with that vaccine, I suspect I'll be asked something like, when will we return to normal? And I'll just start that question with an answer of, I don't know, but I can tell you that this virus is going to be around for some time. We all breathe, we're all at risk. We don't have near enough herd immunity right now to say that by, let's say, January, kids can return to school with no risk and teachers can return to school with no risk. I suspect we're going to see no sense of real normalcy until the fall of next year. That's what we are planning toward, planning with our staff, planning with our vendors. And that's a reasonable plan going forward, I think, for each of us with our families. So I will stop there, and however you wish to open the Q&A, I'm happy to participate.
Very good. Thank you so much, Dr. Luedtke. It's now your turn, leaguers. Go to the Q&A button. I misspoke before and said chat. Go to the Q&A button and ask your questions. And while you're doing that, I want to thank the people you don't see behind this webinar. Rhonda Levisay is the guru behind the presentation, Zoom meetings, and our website. Linda Lynch recruits and coordinates our speakers. Terry Parker and Linda Ferdosian are also helping with the questions you'll be asking. All right, for our first one, Dr. Luedtke, how are daycare facilities handling the distancing and face mask issues? This is especially important since many facilities are closed and parents can't rely upon older family members' care for younger children.
I think it's an ongoing challenge. And when you look at societal disruption, I mean, when we closed down much of our society with the governor's order on March 23rd, I think there was a sigh of relief from many that we needed to take a pause. We needed to do a safety stand down, as we used to say in the Navy. But over the course of a couple of weeks, we realized that, well, that disruption is huge. People have mortgage payments and rent payments. People need to put food on the table. Kids need to learn. So it's an ongoing challenge. And we were fortunate over the course of quite a few weeks to get some good guidance from the Center for Disease Control in various areas, sports venues, daycare, long-term care facilities, etc. Many of us would have liked it to have come earlier. I'm one of those, but I accept that it's really challenging to do this when you just don't know all the specifics of the virus. Like I said at the outset, we told everybody to draw blood to try to test for this virus. Turns out you can't find the virus in the blood. That's the level of things we didn't know. So I believe now we're in a reasonable space with clinical and public health recommendations to keep daycare safe. That being said, as a father of three, it's really hard to keep kids' activities under control. And that is going to be a challenge going forward. And I don't know how we're going to decrease that risk other than the recommendations we have now of cleaning high-touch items frequently, like keyboards and doorknobs, making sure that The ongoing cough etiquette and such is spoken of to everyone in the daycare. Making sure masks are used appropriately for those children, above age 2 that can wear them and not do it in an incorrect way. I hope that answers the question, or at least addresses it partially.
I'm sure it probably addresses it as well as it can be for now. How effective is contact tracing now in Lane County?
We have done really well. The metric that was required for us to move from a closed society to phase 1 was 95% of cases need to be contact traced within 24 hours. Now, that's not too hard to do when society is closed down and people only have 1 or 2 contacts, just people in their house. But once you open societies and people are starting to go out and congregate, they all of a sudden have, and they go to church and they go to synagogue, they all of a sudden have 10, 20, 30, 40 contacts. So it got harder and harder. But we have been able, in Lane County, we have been able to meet that 95% within 24 hours all through the summer up until now. And I will put one little asterisk on that. I'll be the attorney with the disclaimer. The little asterisk is, a couple days ago, we had the highest number of persons under monitoring. It was almost 800. That's a lot of people for us to follow. And we have a pretty deep bench, but our bench isn't unlimited deep. And if we continue on this steep part of the curve, we're going to have challenges meeting that metric. That's going to be tough.
Well, kudos to you and your staff for doing so well. Thank you very much. What measures are undertaken for testing in senior living centers?
So I appreciate that question. The governor mandated that testing takes place at all the long-term care facilities by September 30th, and then there needs to be an ongoing plan for testing staff every 2 weeks, and starting in October, so October 1st. So that is ongoing now, and we are hopeful that each of those facilities are proceeding in that direction. We have seen their plans. We know there's a lot of testing going on, 1,200 to 1,300 tests a day just in Lane County. Lane County laboratories are occurring, not to mention those other big labs I mentioned at the outset that are sent out of state to have their testing done. So those are good things. Those are really good things. And if you've read the headlines over the last few months, nationally, there have been some huge outbreaks in long-term care facilities. Seattle was the first one, right, with quite a few deaths in that nursing home. And we have been fortunate here that we have not had anything of that magnitude. And I think that we need to pat on the back the long-term care facilities for, yes, they've had some cases, but they haven't gone from 1 or 2 residents or a few staff to 50. And we need to keep the pressure on, keep our foot on the accelerator to make sure that it doesn't go in that direction.
Very good. How is Lane County Public Health addressing COVID-19 for the unhoused?
Oh my. So
Yeah.
I will tell you, for a couple months, this was my most sleep preventing challenge. And if you recall, when the governor's March 23rd order to essentially close down for a time each of our communities as part of COVID prevention occurred, that included our community-based organizations who take care of the houseless persons and provide a lot of services. And Lane County stepped up, and we opened up 3 different facilities, 2 on the county fairgrounds and 1 over in Springfield to house houseless persons and to ensure that they had 3 meals a day and a safe place to eat and sleep. And that is not something we natively do. That is not a normal thing that Lane County Public Health does. Prisons and jails, they house inmates, and some of the CBOs do that, but that was a real heavy lift for us. And I remember each day going over to the fairgrounds and assessing infection control, where one of the facilities at the Expo Center, many of you probably have been to the Expo Center on the fairgrounds, it's typically where the livestock are during the county fair. And I'd go in there, there's 150, 160 people in there. That is a group gathering just ripe for any type of communicable illness, whether it's a skin illness like scabies or impetigo, or a respiratory illness like flu or COVID, or a GI illness, some kind of norovirus, cruise ship virus kind of thing. And we got through that whole time without a single outbreak of any kind. And we partnered with St. Vincent de Paul. We really thank them for their help. But I have to say, we were both lucky and we were good. And I hope we don't have to do that again. If we do, I hope both of those hold, the luck and the goodness.
That's amazing. We should be proud of our community, I think. Okay, there's a recent article in a physics journal that concludes face masks are much more effective than face shields. Is the Lane County Health Service recommend, do y'all recommend um, masks over shields? What are you gonna modify your recommendations? What do
So,
you think?
this is an interesting question, and I would say that this really gets to the point of science. And I'm going to have a little digression here. I suspect some of you are looking at the daily reports on the various vaccines for COVID that are out there, and a couple of the companies have paused their trials because there were some untoward sicknesses, and they want to do a deep dive to see if it's related to the vaccine. And that's science in action. That's what science does. Science has a plan, it enacts the plan, it looks at endpoints or surrogate points. If you meet those surrogate points, you continue on. If you don't meet them, you got to look at, is this safe? So it's the same thing with assessing the use of masks and face shields and other PPE, quite frankly, personal protective equipment, PPE. And early on, it was all masks, 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 the first several months of this. And then, of course, there are some people who don't do well in closed environments, and they don't do well with a mask over their face. They may have some kind of post-traumatic stress disorder from that. They may have some sort of phobia. And how do we help them through and still allow them to get out to society and go grocery shopping or something akin to that that would help them and their family? And there was some limited data that appropriate face shields, now not just the little ones that are kind of here, I don't know if all of you can see me, but the ones that go up to your forehead, down below your chin, and wrap around back to your ears, those full face shields, almost like a full face shield motorcycle helmet, those provide some protection. But we do not believe they provide as much protection as the face masks do. And the current state recommendation includes both of them as an option, although clearly the face shields are secondary. And I suspect, given some of the latest science, not just the physics article, but a couple in some epidemiology journals, will probably result in the demotion of the face shield as an option.
Oh, very good. And given all the work you and your staff are doing, someone wants to know, have you and your staff stayed well?
Oh gosh, that's a nice question. I was saying before we went live that many of us have been working really hard, and I recall being in this very office here in the public health building in downtown Eugene. My middle son came back from college. It was his senior year. He was in Boston and the school was closed, and he came back to our house to finish college online, not have a graduation, all those sad milestones that were not met. And each day I get up in the morning to go to work, and after about 40, 50 days, he started to tell me, because he was up doing his coursework because Boston is 3 hours ahead of time. I'd get up and he'd be downstairs online, and I'd get my breakfast at 7 a.m. and I'd leave, and he'd say, "Dad, that's day 51. Dad, that's day 55. When he hit 100 days, I realized that I was in the office 100 days straight, weekends, evenings, everything. And I was not the only one. And we worked really hard to try to keep our community safe. We made some mistakes. I think we did some good things too. And we now are looking at much better schedules, trying, we're still 7 days a week. And we have people who have chosen their 5 days to cover certain weekends and then have, Tuesday, Wednesday off, etc. So I think we're in a better space. We were in a better space. In fact, we were in a pretty good space until the last few weeks, where the number of cases has just really increased, and we're all stressed again. So I appreciate the question. We're doing our best to keep you healthy and our staff as well.
All right. One of our members wants to know, wants to have you comment on herd immunity.
So there's some good things about herd immunity, and there's some unknowns, but there's also some challenging things. So, herd immunity is a concept, and essentially what it means is if enough of the herd is immune, when that bacteria or virus shows up, it can't spread like wildfire to that herd and all the other herds that may be nearby. And in this case, the herd is us. We're humans. We're not cattle. We're not horses. This is the human herd. Now, this virus does not have a requirement for herd immunity as high as something like measles. Measles is so exquisitely communicable, probably one of the most communicable microorganisms around, that you have to have roughly 95% of people immune to prevent wildfire-like outbreaks, great big outbreaks. This virus is not nearly as communicable. We probably only need about 60% of us to be immune to prevent these societally disrupting wildfire-like outbreaks. So that's the good news. I mean, that's a nice thing. Now, how do you achieve herd immunity? There's two main ways. You can either get the infection natively and your body develops the antibodies and you're immune, or you can get a vaccine. Now, there are a few other ways, right? We do immune globulin. We give you a shot of somebody else's antibodies. The president just had some of that when he was in the hospital. He got antibodies. That's really expensive. We don't have nearly enough of that for 330 million Americans. But the two main ways are you either get sick by catching it naturally, so to speak, or you get a vaccine. And right now, we're building herd immunity the only way we have that's possible is people getting sick. And probably, maybe at most 10% of our county has developed some immunity. So we're a long ways from herd immunity, even that lowered 60% that we need to say, yeah, we can open up more.
Okay. I have a member who's asking, how does Lane County Health work with U of O medical staff and university officials coordinate efforts?
Oh, I like that question. So the first case of COVID in America was on January 20th. On that day, I called the university and said, you need to repurpose your laboratories. You have lots of labs. They need to help us with COVID testing. And I'm happy to say we have been working with the university ever since. And when I was at the University of Utah, you mentioned my bio at the outset, I was a professor there. And one of my duties working with Congress, Congress got scared after 9/11. And then if you remember, a couple weeks after 9/11 were the anthrax attacks. And Congress was really scared that there are all these freezers across America in various laboratories that might have anthrax and smallpox and tularemia and plague and all these nasty things. So there was this huge push to do an inventory across the country. And I got tasked with doing the inventory for Utah. And the state of Utah, the University of Utah, has lots of laboratories, and professors do what professors do. They live off of grants and limited money. So if they get a little bit of anthrax, they keep it and they put it in a freezer for the next time a grant opportunity comes. Anyway, I learned from that initiative that there are labs all over, and I assumed the University of Oregon had labs all over the place. So I made that call the first day and said, repurpose those labs. We need your help. And they were probably thinking of it anyway. I'm sure I wasn't the only one who nudged them, but they have done just that. The University of Oregon began testing their athletes when the NCAA allows athletes to come on board. I think it was June 15th in preparation for their season. And they've been testing right along. They proceeded to get their laboratories certified. It's called CLIA certification, so you can test human samples and report the results and bill for them, just like all the other labs at Peace Health and Mackenzie Willamette do. And it's impressive what they've done. And they are now able to do, gosh, I think they're around 1,000 COVID tests a day. It's impressive. And we work very, very closely with them. And one last thing about the university, we had some worries when the students came back on campus for the fall that if they tested, first of all, the goal was to test everyone before they were allowed to be put in a residence hall, which is a great goal. You want to make sure that the residence hall doesn't have any COVID in it, so that's a good thing. But if everyone was tested, and U of O students come from all around the country, some of those places are COVID hotspots, public health could have been overwhelmed if 10% of those new students were positive. So we work with the university for a testing plan. No more than about 500 students could move in each day, and we would get those positive results, and then we do the contact tracing really quick and make sure our community is safe. And we did that. They moved people in, 500 every day for 7 days, roughly 3,500 students. We were not overwhelmed. We definitely had some positive COVID cases in those students, but we endured that, you know, that big rat going through the snake belly, as they say, that big bulge. So a really good cooperation.
Aren't we lucky to live in a place with such astute and conscientious professionals? Thank you. Okay, another question. Do you have a specific date and recommendation regarding COVID cases in the personal service sector, such as massage therapy, spa workers, et cetera, that involves extended and in most cases, hands-on contact?
Oh, that's a hard one. You know, so I will digress just a bit. those of you who have read, and I'm going to assume many of you have, because this is the League of Women Voters after all, I suspect many of you have read the Constitution and the Declaration of Independence. Nowhere in the Constitution is the phrase public health mentioned. In fact, health, the word does not occur anywhere. Health in this country falls in that little clause of the Constitution that says anything not enumerated here is delegated to the states. So health, public health, is delegated to the states. So we, local public health authorities like Lane County Public Health, our boss is the state of Oregon, in this case, the Oregon Health Authority. The Oregon Health Authority has put together all sorts of recommendations for entities such as massage enterprises and daycares and music venues and restaurants, etc. It took some time to do that. I suspect the person who asked this question was pretty frustrated it took so long. But again, just keep in mind, give some grace to public health. We didn't know everything about this virus, and there's still a good deal we don't know. So that's my first preamble. The second preamble is there are several ways this virus can be transmitted. We believe the vast majority of it is these large droplets that happen when we cough or sneeze or talk or sing. Those large droplets are heavy enough, they fall to the ground within 6, 7, 8 feet of the person who is producing those droplets. And that is the majority of cases transmission occur that way. But you can also have contact transmission, which is what this questioner is getting at. Namely, you cough into your hand, then you go shake somebody's hand. Well, then they get it on their hand, then they touch their nose or push up their glasses, and they infect themselves. Contact transmission can occur with COVID. We think it's a significantly smaller amount, but it's not zero. So I don't have a date for when these things will change. We rely on the state. And many of us in local public health staff the committees that the state uses to make those determinations, review all the research, look at the latest in epidemiology journals, public health journals, medical journals. So I can't give you the line in the sand, but just it's a process and we're all working on it together.
Very good, thank you. Here's probably another hard one. What voice is best to listen to regarding whether a December vaccine is safe?
You know, I don't know if any of you signed up to be part of these trials. Moderna, Pfizer, some of these big pharmaceutical companies had a nationwide opportunity. Anybody could sign up and you may get chosen. I signed up, I didn't get chosen. I feel kind of badly about that, but that's the way randomization goes. You get chosen or you don't. And the system being put in place to approve these vaccines, I feel confident about. And the reason being is we've had vaccines for years, and many of the vaccines have really changed our society and made us a healthier space. And most of those, when you get to phase 3 trials, there are roughly 15,000 people who are tested. And the FDA said, we need more data and we need it more quickly because we're in a pandemic. So they've doubled the number of persons in phase 3 trials to 30,000. So that will give you more data more quickly. Also, when you look at the review of that data, the efficacy of the vaccine, does it really prevent COVID or provide you immunity that is effective? It's typically reviewed by the company, which, you know, companies can be biased, right? They want their product on the market, they want to get money. It's also reviewed by governmental employees who may be biased, saying we got to be safe, safe, safe. But sometimes during a pandemic, you got to move the needle a little bit and take a little bit of risk. So now for this particular set of vaccines, there's a third review by non-governmental, non-industry, trying to make sure that it's done in a way that will ensure safety. And it's a group of experts. A fair number of them will be academics. Some of them will not be. There'll be people in the clinical space. And I think that is reassuring as well. So no vaccine is perfect. These COVID vaccines are not going to be perfect. There will be, when you start to give vaccine to 1 million people, you're going to see 1 or 2 weird side effects. That's just the way this works. But they're going to be, in my estimation, every bit as safe as the other vaccines that we pushed out in the system where we only tested 15,000 people. So I have faith that it's going to work appropriately. And when the vaccine arrives and my group gets called as one of the priorities, I'm going to give up my arm and get stabbed. Absolutely.
Very good. Is there a name for that third organization that we could look for?
Oh, you know, I don't know it offhand. I can find it out though, and I could maybe share it. I don't know how you could get it up on your website or something, but I'm sure there's a title, there's a name for it.
Very good. Thank you. That would probably be helpful to our voracious readers and researchers that belong to the league. Okay, and I think you probably have already answered, but it wouldn't hurt if we were a bit redundant. What is the single most helpful behavior that we can do as members of the public to help prevent the spread of this disease in our day-to-day lives?
You know, this is a respiratory agent, and I think being cognizant of where your breath goes and where your intake breath comes from is the most important. So that typically means covering your face with a mask and using that mask appropriately. That is number one, but that is nuanced, right? You don't wear the same mask every day for 6 weeks. You get it saturated and you got to wash it. You need a clean one every day. So use a mask and use it appropriately.
Very good. Let's see. I had someone ask, do we really have to cancel Thanksgiving dinner?
I'm not canceling Thanksgiving dinner, so I don't think you have to. Typically in a cohort, what we call that cohort of persons who are at home sharing air all day long, yes, there's transmission there, but you can prevent that transmission by everybody being safe when they're outside, and once they come back together, maintaining safety. I think you can have a safe Thanksgiving dinner. I think it would be hard to have one in a typical home size of 1,800 square feet, 2,000 square feet with 30 people in it. That would be really tough. But having a Thanksgiving dinner with 6 or 8 of you, you can find a way to do it safely. Just be thoughtful really about the big items. Wearing a mask, reasonable social distancing, and cleaning those high touch items and doing that screening ahead of time. If somebody's sick with a respiratory illness, I would suggest they disinvite themselves.
Actually, that sounds better than some of the political arguments that might go on during Thanksgiving dinner. Okay, now I have someone asking, why are the number of case counts reported by Lane County often different from OHA?
So that's a really good question, and this is something we endure for all of the reportable diseases. We will report syphilis, gonorrhea, E. coli, salmonella, and they'll be different by a little bit. And part of the reason is we are an island of population in central/southern Oregon. Our hospitals are big referral sites. Peace Health gets patients from Coos, Curry, and Douglas and Lynn all the time. And we really strive hard with all 36 counties to make sure none of the cases are double counted. So, for example, a day last week, Peace Health had something like 23 patients with COVID in there, and 6 of them were not Lane County citizens. So the initial report might have said 26 with an asterisk until we tease out where all of those patients come from. And then we find out where they live. Some people have 2 homes, which is kind of a surprise. And if they're intubated, they can't tell us which one is their normal home, if they're on a ventilator. So I would ask that people understand that there's a lot of work behind the scenes to really make sure we're not double counting. And we work with all the other health departments literally every single day to make sure that's the case.
Very good. Well, it looks like we may have run out of questions. Well, here's one. I think you might have explained this. One of our members gets information every day about how many new cases, but I never see a chart showing the path of the virus over time in Oregon or Lane County. Are such charts available?
They absolutely are. In fact, if you go to the Lane County Public Health website and you just click on the tab for COVID, we have those graphs. And you'll see that we had the March, April like this, and we dropped off in June, July, and then September, this. And we absolutely have that. And then next to those charts with the graphs, you'll see all the numbers that tell you the total number of cases. So absolutely, it's all available, publicly available.
All right. Well, I think we've reached the end of the questions. So thank you again to you and your staff and all the other folks. Send our gratitude. We really appreciate it. And same to our members. Thanks for your attention and astute questions. And thank you again, Dr. Luedtke. Thank you very, very much for answering our questions. I think you probably went a long way to ease our minds and answer some pressing questions. To the rest of y'all, sign in again next month, November 19th, for our third Thursday then. We will hear from Representative Nancy Nathanson. Goodbye, be well, and stay that way.